Dear Pro-Rector, dear members of Corona, dear... oh, okay, sorry. Oh, sorry. Oh, sorry. I was too excited.
Too enthusiastic.
Yeah.
Hereby I open this academic ceremony in which Daša Kokole will defend the academic thesis Scaling Up Alcohol Prevention in Primary Healthcare, exploring factors influencing alcohol screening in Colombia, Mexico, and Peru. I invite you to present a summary of your study and the conclusion of your thesis.
Thank you, dear Pro-Rector. Dear Pro-Rector, dear members of Corona, dear colleagues, dear family and friends, here and online. Welcome, and thank you for being here today. In the next 15 minutes, I will present the key findings of the research done in my thesis. But before we start, do you mind if I just ask you a few questions? Just think along with me as I ask them. 1. How often do you have a drink containing alcohol? Never? Less than monthly? Monthly? Weekly? More often than that? And when you do drink alcohol, how many drinks do you have on a typical day? Bear in mind that one drink is one small glass of beer, small glass of wine, or a small shot of spirits. And finally, how often do you have 6 or more drinks on one occasion? For example, how often do you end up emptying almost a whole bottle of wine on a night out? Some of you might have answered the questions like this. You usually drink 2 or 3 times a week, 1 or 2 drinks per occasion, but once a month you also end up drinking a bit more in good company. Did you ever consider that this amount of alcohol, even if it might not seem much to some, can lead to risk for health harm? For example, did you know that no amount of alcohol is healthy for you, and 1 glass of red wine being good for you is a myth supported by the flawed studies and promotion of the narrative by the alcohol producers? And there are numerous other diseases for which alcohol has detrimental impact, including 7 types of cancer, for which there is no safe level of consumption. Also, on a more short-term note, maybe you notice that even just after drinking a glass or 2 in the evening, alcohol interferes with your sleep. If you want, we could think together whether you would like to reduce your consumption and how to do so. Now, I will not make you actually do it, but this is a very brief representation of how primary care providers could discuss alcohol with their patients in their consultations. The questions I asked at the beginning are part of the Audit C questionnaire, which is a commonly used screening tool to identify whether someone's level of drinking is already causing them harm or might be causing them harm in future. And this is what we have been asking the participating providers in the SCALA project to do, to conduct alcohol screening using the Audit C questionnaire. Alcohol is still not often discussed during consultation for different reasons. Providers don't have enough knowledge about alcohol, don't have time for it, or might just feel hypocritical telling their patients to drink less while they themselves still drink. SCALA project was a collaboration between institutions in Europe and Latin America and took place in 3 Latin American countries, Colombia, Mexico, and Peru. Its main aim was to identify which combination of so-called implementation strategies worked best for increasing alcohol screening by the healthcare providers in primary care practices. To investigate this, we devised a quasi-experimental study in which we investigated to what extent training and community support were able to increase provider screening. Against this backdrop of a broader study design, what I will focus on today is presentation of findings from the research in my thesis, which focused on investigation of factors influencing alcohol screening as part of the SCALA project. The presentation will follow the main aims of the thesis. First, I will talk about the results from a pre-study stakeholder survey, assessing the appropriateness of the intervention and barriers to its implementation. Secondly, I will present development of the process evaluation protocol. And finally, and most importantly, I will summarize the factors found to actually influence alcohol screening in the 3 countries on the level of implementation strategy, individual, organization, and the wider environment. First, before the start of the study, we surveyed the key stakeholders in the 3 countries, which was a group consisting of providers, center managers, and other relevant local stakeholders with experience either in primary care or alcohol screening, on their perception on how the intervention fits with the setting in the 3 countries, and what are the perceived barriers to its implementation in practice. The results of the survey showed that alcohol screening and brief advice were seen as an appropriate approach to reduce heavy alcohol use in primary healthcare, and a range of providers, such as doctors, nurses, psychologists, and social workers, were considered suitable for its implementation. The highest rated barriers were similar between the 3 countries and included patients' normalized perception of their heavy drinking, lack of ongoing support for the providers, difficulty in accessing referral services, and lenient alcohol control laws. Next, we developed a process evaluation protocol. For those of you who are not from the field, when we talk about effectiveness of an intervention, we usually have in mind outcome evaluation, which deals only with whether intervention works or not. What I am focusing here is process evaluation, which deals with why did the intervention work or fail. It deals with questions such as through which mechanisms did it work, for whom and in what kind of context was it effective, and through which and how is all this interrelated to help explain the obtained outcome. We used a range of different methods, such as questionnaires, observation, interviews, document analysis, and logbooks, and obtained information from a range of sources, such as implementers, providers, and patients, to identify how were the different factors associated with the outcome and what were the key drivers of the increased alcohol screening implementation. But early on in the data collection process, it became apparent we were working with 3 quite different countries and different organizational contexts. While all 3 countries make progress in universal healthcare over the recent decades, the primary care in Colombia and Mexico during the time of the project was prioritized to a greater extent than Peru, where there was a mental health care reform, which at the time of the project focused on establishment of community mental health care centers. That's redirecting all of the resources and priorities away from primary care. Also, in Peru, alcohol was still seen through addiction lens, both in policy documents and by the providers. This means the focus was mainly on people with alcohol use disorders and people with problems, rather than through public health lens, so focusing on health harms on population level. In Mexico, there are actually existing normatives, so policies which require providers to include some information on alcohol use when taking patients' history. So the providers were already familiar with the instruments such as Audit C, which was not the case in other 2 countries. On an organizational level, while the primary care centers were recruited by the research teams in the countries, the centers' leaders themselves could decide how to recruit providers in their centers, to institutionally mandate their participation and let them opt out, or to have them to opt in and sign up voluntarily, which to a certain degree indicated either commitment of the organizational leadership of the center or their organizational culture and practices. In Colombia, one of the project champions also held an influential position on organizational level in intervention municipality. And finally, when surveying the providers at the baseline, we also found differences in some motivational factors. For example, the Mexican providers had the highest alcohol screening self-efficacy, which makes sense knowing there was some kind of existing practice in the country. And Peruvian providers had the highest therapeutic commitment, which can be explained by having to voluntarily sign up for participation in the study. So, Based on connecting data collected through process evaluation with the outcome data, what did we find? The key common drivers of screening were whether the providers received training or not, and how much training they received, and whether there was perceived leadership support on organizational level, at least in the intervention arms. There were also some country-specific drivers. Self-efficacy at baseline was associated with higher proportion of patients screened, but only in context with existing practice, and I hope by now you've learned the country flags. And the professional role, it depended on the established healthcare systems in the country, whether, for example, psychologists were more likely to participate and screen, or whether doctors and nurses did so. But this was all on level of individual provider behavior, and in the period before COVID-19. What happens if we consider also how many patients were reached? What I'm going to show you now is the data from the whole implementation period of more than a year, including a COVID-19 disruption, which led to a pause on activities to different extents in different countries. The first graph shows how many of the participating providers, many of the providers who were participating in the study did any screening during the implementation period. We can see that while the absolute number of providers doing any screening was highest in Mexico, so country with existing practice, in Colombia, there was highest proportion of screeners among all of the participating providers. In the second graph, you can also see that the Colombian providers on average screened much higher number of patients compared to providers from the other two countries. So when looking at the total number of the patients screened, we see that the numbers are higher in Colombia and Mexico, countries with prioritization of primary care and public health approach to alcohol, and either strong organizational initiative, as was the case in Colombia, or existing policies related to alcohol screening, as was the case in Mexico. In Peru, on the other hand, a range of factors coincided to create a very unsupportive context. Political instability on country level trickled down to level of health authorities. There was previously mentioned lack of focus on strengthening primary care during the project time, alcohol still being seen as an addiction issue to only be treated by specialists, and of course, COVID-19 impact on healthcare. Peru was arguably hit the hardest among all of the three countries, although all three suffered quite a lot. And all of those factors together could explain the lower proportion of screening providers and the patients screened. So, in conclusion, what the evaluation of the factors influencing implementation of alcohol screening showed is that to change individual provider behavior, factors on a range of levels are important. Implementation strategy, individual provider level, organizational level, and level of wider environment. To increase the patient reach, however, this has been shown to be achieved either through strong organizational initiative and leadership, or in a context with existing national policies on screening. So, to scale up alcohol screening in primary healthcare, any future efforts should combine skills-based training tailored to the local setting with action focused on community, organizational, and policy levels. Thank you. And I give the word back to the prorector.
Thank you very much. And thank you for your presentation, which I think gave a nice overview of the work you've done. It's now time to start with the opposition. And the opposition will be opened by Professor Krutsen. He's Professor of Behavior Change and Technology at Maastricht University.
Thank you very much, dear candidates. Congratulations on your thesis. Well done. Also, on behalf of the chair, I can report that everybody was happy with your work, and that's why you're standing here, rightly so. Also, I myself think it's an impressive piece of work on a topic that I think is dear to your heart. You conducted it in a challenging setting, which you just explained, and there were some extra challenges as well, which you didn't anticipate at the beginning of the project. And I think it was a very interesting approach that you focus on scaling up from the get-go. Of course, I'm also here to ask questions, and my first question is about Chapter 4. And that was actually triggered by the first sentence of the result in your abstract, which starts with the word training reach was high. And then I start reading that, and then you see that 72.3% participated in, did something, meaning participated in one or more training or booster sessions. And of those, then 49% actually did some screening, which I can imagine, because learning is step one, but then doing it something else. And then, of course, the question is, what does that do to the patients? But I actually want to focus on this very first step. Do you consider training reach to be high? And the way I ask it, you can see that's not a neutral question, because I think that you also think that it's a pity that we, more than 1 in 4 professionals, we lose them already before they even start. And that is not with, like, I truly respect all the efforts you took, but I think you also had your thoughts on why it is, and maybe more important, how could we improve this?
Hi, listed opponent. Thank you for your compliments and question. In terms of general reach at the beginning of the study, I would still stand that for the context we were doing it in, the reach is high, because it was not so easy, first of all, to get the providers to participate in the study, and then also to get them to the to attend the trainings. There were many other, for example, in Colombia and Mexico, there were many other competing priorities. In Peru, there was unsupportive context, as I just mentioned. So in that sense, of course, ideally, we would get 100% reach of the providers that have joined the study. But the case was just that, providers who signed up for the study then dropped out at some point. And that also, in a way, counts in the reach, just because they had other priorities and they didn't want to, they didn't prioritize participation in such a study anymore. What I would also mention here is that just this reach number by itself does not tell us the full story. For example, in Mexico, we had there was a case that apparently some of the providers who participated in the training were able to then share this knowledge with the other providers who did not participate, just because they had conflicting obligations during the training time, but they were still interested in participating or learning more about the topic. So there was basically more providers in the end being trained that are not counted in this 72.3% of reach. So I would still say I still consider that quite a high number for the context we were working in.
Yeah, I fully agree, of course, and I said I admire your effort, but I was just thinking in terms of, like, if you think scale up, Scala 2.0 or scale upper, should we then think in terms of, for example, licensing of professionals, or maybe going to education at the educational curriculum or something like that, where we can reach them, like, right from the start? Is that an idea? That, like,
definitely. I mean, one thing would be to already embed this kind of trainings. I mean, ultimately, it's not a very long training. It's between 2 and 4 hours, so it could be embedded in the training or in just the education curriculum for the healthcare professionals, because they don't get really much education on substance use problems during their educational path. So in that sense, for properly scaling up, the training would have to be embedded as part of some broader initiative.
And you already mentioned, like, in Mexico, it was already common practice, or at least more common practice. But is it there part of the training curriculum then already, or?
I think the common practice I was referring to is mainly that there are normatives where they have to. They're required to use some of the screening instruments, like audits, or I think full audit or CAGE, when they're taking the patient's history for the first time. So it's not like they have to talk to every patient, but because of those normatives, they are more familiar with this kind of approach and this kind of instruments. I'm not aware if that's part also of their training.
So that's more like a guideline.
But it's stricter than guideline. Guideline is a suggestion. These normatives is like official normatives. That's what they have to do.
Okay, clear. Thank you. And then my second question goes to chapter 5, where you say, and you also touch upon that in your presentation, that higher self-efficacy is a very relevant factor in settings where screening practice is already ongoing, just as in Mexico. And that seems very plausible to me. And then I looked at table 4 in that chapter, and then we see actually that participants just scored above average. And it's not only in Mexico, in all 3 countries, I think it was 3.3 on average, I've written down here. So basically in all these 3 countries, they just score about average in terms of self-efficacy. So that makes me wonder, so there's clearly room for improvement. That makes me wonder, how was self-efficacy addressed within Scala? Because I saw a brief summary on page 16, what Scala all entailed. But can you tell me a bit more about that? What did you do in Scala to boost the self-efficacy of participants?
So the main basically the whole implementation strategy that was in a way targeting self-efficacy was the training, because training was based on modeling through videos, which were pre-made and they were being shown at the training, but also there was really a lot of focus on the role-playing practices. So the providers could just practice it on the training itself. And that was the way that we wanted to, in a way, increase and stimulate their self-efficacy. What we saw in practice is that the role-playing was very well accepted, and providers were really happy to have this opportunity to practice, but there were also just time issues with role-playing not being completely done, being able to be done to the extent envisioned, because the idea was that for each part of the screening and brief intervention, the provider gets both in the provider role but also in the patient role, so it received the screening. But often that didn't really work out, which is enough time. There wasn't enough time for the exchanges in pairs. But then what we saw, that's not in the thesis, but that's in the process evaluation data deliverable that was done separately for the project, is that the trainings had highest impact in Peru on self-efficacy. I mean, I talk about that also a bit in this thesis, that Peruvian providers seemed to be most content and satisfied with the trainings because there was just so little other support. So in that kind of in Peruvian context, the training had biggest impacts on self-efficacy.
Okay, and that's a bit in the land of the blind. Is that a bit in the land of the blind?
Land of the blind?
Yeah, like there was nothing there, so the only thing, you said like in the Peruvian context, they were so glad that they already received something. Is that how I see it?
Yeah.
Okay, thank you.
Because there was not much other support, and like in terms of training, they were just very happy to receive this education, but also to be in a way in the group of like-minded people who also were interested in this topic.
All right, thank you very much. I give the word back to the prorector.
Thank you, Professor Krutse. The opposition will be continued by Professor van der Weijden, Professor of Implementation of Clinical Practice Guidelines at Maastricht University.
Thank you, Mrs. Prorector. And dear candidate, it was a pleasure to reading your beautiful thesis, your relevant thesis. You confronted us with the questions in the beginning of your presentation. It's so relevant in every country to improve alcohol behavior. And it's, for me, actually the first time to read a whole thesis on process evaluation. And you and your team are to be complimented for that. It's so important. And we do a lot of implementation research, also in the primary care setting. It's so complex. And these beautiful, dedicated doctors are so willing to work on alcohol screening, but they are so busy with their patients on all aspects. It's a very colorful thesis. I also like the way how you visualize your beautiful results. It really helped me with bar graphs and colors, so very nice. My question is about these methods for process evaluations. We do it a lot. It's a struggle. It's so labor intensive. You had so many data. It's such a lot of work. But first, in your protocol, you talk about reach, dose, and fidelity as the most important variables, apart from adaptation. In your introduction, you refer to Proctor, and there are so many variables in process evaluations, and the definitions are confusing sometimes. Can you very briefly define reach, dose, and fidelity for me?
Highly esteemed opponent, thank you for your compliments and questions. So, reach,
dose and fidelity.
Reach overall is just defined as the number of, first of all, I would preamble this by saying that in a way the definitions can be related to the intervention itself.
Yes.
You can have like a broader definition, but I'm going to define it in the context of our intervention.
For Scala, can you define it for your project?
So in our case, the reach was on different levels. One was on level of providers, as we also just discussed. How many providers who participated in the study?
On the different components. And then dose.
Okay, dose. It's in my thesis I looked specifically at the dose of the training, and that was in terms of how much of the there's two things. There's those delivered and those received. And those delivered is how many sessions were offered, and those received is how many of those offered sessions were actually being attended by the providers.
So reach is more about quantity, they participated yes, no, and dose is more quality. Yeah?
In our dose was still in terms of amount, I would say.
Okay, amount.
But reach in terms of...
Yeah, I'm pressing you. We have only a very short time. So what's then fidelity?
Fidelity was to what extent were the elements, for example, in our case, the training, delivered as intended.
As intended, so we already we noticed that how difficult the definitions can be. And can you, because we try to do process evaluations more and more, but we cannot, it's costly. Can you, from the beautiful mixed methods that you've been using, and I've listed them here for myself, if I have to write a proposal today, which method should minimally be mentioned in my proposal? Of the questionnaires, the interviews, the observations, the document, etc. It's a crude question, I realize that, but try to give your first intuition.
I think the first thing, also to minimize the impacts on people being studied, is document analysis of whatever's already there. Then it's more work for you, but less work for them. I think if there are questionnaires used, I would try to make it very, very brief and not too long, because that's... we also saw in our case that at the baseline there was a high, quite many providers responding to the questions, which really drops towards the end. I think, interviews are helpful, but again, very time and resource intensive. So just choose some of it. I would put that as those three. And the second thing, if I may add, I think what I would start exploring now, that's something that I was thinking quite a lot now with the whole race of the AI tools and how the AI can be used in the also in research.
AI, artificial
intelligence. For example, now Atlas analysis tool already has AI help with coding. So this kind of things can be helpful.
So we're already then thinking about how to analyze data in an efficient way. I miss the observations. I think the observations are so strong, but also very time intensive and labor intensive. If I'm allowed, one more short question. I really like that you have framed a variable which is named adaptation in your protocol. My last question is, can you advise me if I have to write a protocol and the intervention like Scala has to be developed yet, should we invest on the beginning of the process, so co-creation and action research to develop the implementation strategies together with the end users, or should we invest in your rich process evaluations during the implementation period of the intervention?
With resource limitations or without resource limitations?
Sorry, I didn't get...
With resource limitations or without?
Without. You have all the money.
Then I think the best approach is to start already with the whole co-creation and all of the pre-study investigations, and then develop. Set in place how will the data be collected throughout the projects, and then collect that. So I think that it's not either or within that respect. Okay. So that, but again, there's resource limitations.
Well, I'm happy with your answers. I really tried to get you to simple answers, but you are a real scientist, and you really did have a lot of nuances. So thank you. I'm satisfied. I give the word back to the pro-rector. Thank you.
Thank you very much, Professor van der Weijden. The next opponent is Dr. Abidi. She's postdoctoral researcher at the Department of Health Promotion at Maastricht University.
Yes. Dear candidates, first I would like to congratulate you and your team on your achievements. I found it very interesting to read that you've investigated alcohol screening implementation from various angles, looking at factors at different levels, very broad organizational levels, and even wider factors, but also very specific individual provider level factors. So I thought that was quite comprehensive. And you've used a mixed methods approach, which really shows, I think, the skill set that you had to master to conduct these studies. So I'm very impressed with the work that you've done in your thesis. So very well done. Moving on to my questions. In chapter 5, you describe differences in baseline predictors of alcohol screening. And you found some very interesting results. For instance, self-efficacy was associated with alcohol screening only in Mexico. Providers in Peru had the lowest role security. And also low self-efficacy scores. And you provide interesting explanations for that, saying that in Mexico, alcohol screening is already quite embedded in routine practice. And in Peru, providers were perhaps less experienced, as you also, I think, touched upon in your presentation today. In chapter 4 and 6, you also highlight cross-country differences. Again, in Peru, alcohol is considered an addictive substance, as you say, not really being recognized as a public health issue. And it were also mostly the psychologists there that were involved in alcohol screening, and the medical doctors much less. So, reflecting back on all these findings, do you think that different implementation strategies are needed in these countries? Taking more into account the different socio-political context of each country? And if so, what other implementation strategies would you use besides the very comprehensive package that you already investigated?
Mm-hmm. Esteemed opponent, thank you for your compliments and question. That will make me think in terms of broader or other possible implementation strategies. I think, if I can just preface with saying that we've seen that training is useful in basically any context, even if it's a bit more unsupportive, like it was in Peru, and community support over the long term was also a very, very helpful implementation strategy. I would actually say that these two, if these two are already managed to be implemented, to the extent intended, maybe even more than now, that's already a lot. But in terms of other implementation strategies, maybe what I would recommend is to think a bit more in implementation strategies which related to policy making, because ultimately we see that the importance of the policy environment and policy context. Then that requires quite a different sets of activities, like meetings with policymakers, preparations of policy documents, or these kind of things.
Mm-hmm. Yeah.
So that's one thing that I would go in. And the second thing is, something maybe still more targeted at patients. I mean, like what we've seen also in the from some qualitative data is that doctors reported often that patients were just not really ready to be asked about alcohol, or they didn't want to share their consumption, or were maybe even lying about their consumption. So there is still a lot to be done on patient level.
Yeah, okay. And in terms of policies, because you mentioned that perhaps, on a policy level, something can be done there. Do you have any ideas about what specific types of policies might be really effective in specifically Peru, Mexico, and Colombia?
I mean, what I was referring to was more the whole policy as official standards, as was in Mexico, to screen specifically to do it. But on the other hand, it's also, this policy in Mexico was feasible because of how the primary care was structured and how how the whole health system were structured ultimately. So it's the feasibility of this kind of policy just related to alcohol screening depends on the developments on healthcare system level. But then, if we're already talking about policies more broadly, I think all of the three countries still have more to be done just in terms of the general best buys in terms of taxation or restricting advertising or restricting availability. That's something that's supposed to be always working. So that's their direction.
Mm-hmm. And can I ask one follow-up question? Yeah. So those are really interesting points that you mentioned, and specifically about those healthcare systems, the differences between the countries. Would there be some kind of healthcare system reform needed then, for example, in Peru, or would there be what could Peru learn perhaps from what is already being done in terms of how the healthcare systems work in Mexico and Colombia?
Yeah, I mean, in a way, Peru was already in the process of that reform during the time of our project. So it was just that for example, in Colombia and Mexico, I think it was 2015-16, where they reformed the primary care with these integrated models of primary care, whereas in Peru, they framed it more as mental health care. So now there was also this community mental health care reform taking place, which in total, it focused also on primary care level and on establishment of community mental health care centers. But the fact was just that during the time that this project was implemented, all the focus was being on, redirected away from primary care. But Peru is actually already in that process of reform. So they're on their way.
Yes. Okay. Thank you very much.
Thank you, Dr. Abidi. Then the opposition will be continued by Dr. Dupont. He's Assistant Professor Addiction Prevention at Maastricht University.
Yeah, thank you very much. Dear candidate, I want to congratulate you on your elaborated thesis and your promoters, of course. Actually, you bring together two of my big loves, namely Latin America and alcohol prevention, so thank you for that. I've read it con mucho gusto, and hace como por 32 años fui a Mexico para mi viaje matrimonial, so I was in for my honeymoon in Mexico, so it brings back a lot of memories and also a lot of memories about alcohol prevention. When you travel in Latin America, one thing that comes to my mind is almost the first thing comes to my mind if you look at the differences between countries, it is the population, how the population is built. And then we see, for instance, that Peru is about 50% indigenous people, while as Colombia is less than 5% indigenous people. Mexico looks a bit like Colombia, I would say. That brings me to my first question. why did you choose these 3 countries and not, for instance, Bolivia or Guatemala and Uruguay and Argentina or Suriname to make a better comparison? Could you reflect on that?
Esteemed opponent, thank you very much for your compliments and question. I would like to preface this question by saying that overall we were working with low and middle income countries where the alcohol use is projected to increase. So that was the broader background for selecting something from this region. But in terms of selection of specific those 3 countries, it was also a bit more of a practical consideration. Namely, this research was part of a broader Horizon 2020 projects, and already when you develop the proposal, you have to have very reliable partners to go into the project with you. My colleagues who were developing the proposal, I myself, I joined later, they just identified reliable partners in those countries. So there are some practical considerations here as well. So that we ensure that whatever we implement, it's more likely to be implemented.
Could you reflect or hypothesize on the way the population is built? For instance, Peru or Bolivia, they have a larger part of Indians, like Guatemala. How does that influence the results you find? Just a reflection on that.
To be completely honest, I didn't look that much into the structure of population. For example, one thing that we saw was what was the case in Colombia, in the municipality where the intervention was taking place, Soacha, there was a lot of displaced population, so a lot of migrants from Venezuela people, basically refugees from other parts. I'm not sure if they were indigenous or not, but that made it much harder for the providers to establish relationships with their patients, and that would facilitate discussing topics such as alcohol. So that was one example when that showed up. For the rest, in terms of population structure, I think what we heard, or what might be one consideration is the whole class differences between the implementers and the potentially doctors who might be more of European descent, and then indigenous populations. But I'm not informed enough about that to be able to reflect on it more.
Okay. So I have another question about chapter 6, and well, you brought it up in the introduction as well. There you say alcohol, it's about Peru, alcohol is considered as an addiction rather than a public health issue. I was shocked because my whole career was about addiction and I thought I was working in public health. But well, you gave me an insight that that might be, I might have to stop altogether, but no, let's not make a big joke about it. But as you look into, for instance, the number of alcohol that is used, that's supposed to be a good predictor of the number of alcoholics in a society. It was Lederman in the 50s of the last century who did research on this. His research is sort of objected, but we still have the general idea that there is a relationship between the number of alcohol used and the number of problems that occur in a society. Having said this, I go back to your introduction where you talk about the 3 best buys of the WHO. And what I was going to ask you, or what I want to ask you here, is a reflection on, for instance, the price of alcohol in these 3 countries compared to the average wage, and how does that influence the outcome of your studies? Because I was looking for it all over in your beautiful thesis, but I couldn't find it. So maybe you could have a reflection now, because if you, for instance, look at if a beer would cost €1 and you earn like 100 euros a month, then it's comparable to paying €20 here for a beer, and nobody would drink as much beer as they do now. So could you reflect on that?
Yes. Overall, I don't know what our prices are in the countries at the moment. What I can say in general is that what we tend to see that lower price and higher affordability is associated with increased alcohol consumption. There's been a lot of research, mainly from the high-income countries, showing that. So I would assume this would also hold in the Latin American countries, but of course, we would need to do proper research to see how is price and affordability related to alcohol consumption in line or in the context of certain wages. Can I just add something to that? Or to your previous comment, in sense of addiction versus public health issue, and how you that you thought that you were working in public health. I think here what public health encompasses the addiction perspective, whereas the addiction does not necessarily encompass the public health perspective.
Okay, that's what I sort of understood already.
Okay, good.
Thank you.
Thank you very much, Dr. Dupont. The next opponent is Dr. Bessems. She's assistant professor at the Department of Health Promotion at this university.
Thank you, Pro-Rector. Dear candidates, first of all, I would like to congratulate you on the innovative work you did in the SCALA project. Collaborating with colleagues from different backgrounds and countries, conducting research in 3 countries in Latin America, from a distance here in Europe, and in another part of the world, being challenged with mixed method approaches and being part of a project during COVID times, well, this must have been a major challenge for you. At the same time, you still did some very innovative studies, I think, and it's not surprising to me to see that all of your studies in this thesis have already been published. So also a big compliment for that to you. So my question goes a bit more depth into the training you have been doing. Because in chapter 5 you describe, and I quote you, increasing provider self-efficacy could be achieved through theory-based training that incorporates evidence-based methods. So first I'd like to hear from you, which elements of the training do you consider the theory-based components of the training in the SCALA project?
Esteemed opponent, thank you for compliments and question. In terms of training, it's pretty simple. It's the videos and the role-playing that are the theory-based. But what we also seen in, for example, an example of Mexico, where the videos were not best accepted and they had to be replaced. They were replaced with cases, just basically real cases that doctors or nurses themselves suggested, so they could actually practice on those real cases.
Yeah, okay. So that then includes still the same components, theory-based components.
Yes, still in the same spirits of it.
Yeah.
It's just not through video, but it's through real life.
Yeah, okay. So one of your conclusions in chapter 4 was that the dose received was a key factor in screening for alcohol practice. So what would this then mean for the theory-based elements of the training, such as these role plays, for example? Should a project team in SCALA focus more on the core components of the training, or should they just spend more time on the training? So is it more a matter of quality of delivery or quantity of delivery?
I think it's both. It's also about what's possible in a given time frame and a given that the providers have. I would say that the quality is important, especially in terms of in also getting trainers' feedback to their practice. So then you need like quantity of practice. I think providers, if they will go through the protocol more often and practice how it is to talk to the patients more often, that will definitely increase their self-efficacy. But also, the feedback is necessary so they do the right thing. And I think in our within our time span for the trainings. Of course, the trainers were trying to give them feedback, but sometimes there just wasn't time for everything.
Okay, so it's a combination of both.
Yeah.
And one thing you also added was adaptation to this. So how does this adaptation actually influence the dose, the quantitative and the qualitative part of the training?
I mean, first level adaptation was already on country level. For example, the length of the training was adapted on country level, because in some countries the providers just had much more knowledge. For example, in Mexico, they were familiar with instruments such as Odyssey, so and they had like quite well defined all of the referral pathways, so that was already part of their institutional knowledge, so to say. So then they could really focus a bit more on the practicing the interactions with the new provided protocol. Whereas in Peru, they had to start from scratch, and so the trainings had to be quite long in terms of 2 hours first training, 2 hours to second training, and 2 hours booster session. So that's adaptation on the country level. Second thing is adaptation on the level of the trainings itself, which they were done on by, in a way, part of it was done before the training started, but it was also just continuous improvement happening throughout the training sessions. But we tried to keep the role plays and videos as it was, and then adaptations to the things such as quiz at the beginning on alcohol attitudes that could be tailored to the country.
Yeah. Okay. Well, what I then kind of also find surprising is that the satisfaction of the training and the perceived utility of the training was not related to the outcome screening. How would you then explain that?
That's because it was just so high that there was not much differences. So there was like not much room for differences. I mean, if you look at the numbers, it's all quite above 4 on a 5-point scale. So in that sense, providers were just they were happy to receive training, or maybe they're just very friendly Latin American providers who wanted to give us good feedback. But I would say that that's the reason. Although we see, when we look at the country differences, in Peru there was actually a slight difference between screening and non-screening providers on training satisfaction.
Okay, so you do consider it important that it's actually evaluated well by the professionals?
I think it's still important to get their feedback. On that. Yeah.
Is there room for one small question? No? 1 minute, okay. One of the things you have described is also the lessons learned in collaborating with all the researchers and the practitioners. And of course, this might be easier said than done in such a project. So I was wondering, how can you keep a balance between the different interests of all the stakeholders, and how can you make sure that your objectivity as a researcher still is there?
I would say that what was very helpful for us in just the first thing was it was still important to establish a relationship, so you're not completely objective researcher just standing in the back doing nothing. You still, or as in it was not as if I was completely external evaluator who would not know anybody doing this. We were still had this project meetings in the beginning, so some relationships were established. But I didn't see that as necessarily negative. I think already the fact that there was somebody a bit external, also in a way on the other continent, so to say, to evaluate it, helped to achieve more of the objectivity. And I think in the end we didn't have that much problem with that.
Thank you.
Thank you, Dr. Bessems. Then it's time for the last opponent, Professor van den Borne, Professor of Patient Education at Maastricht University.
Thank you, Reiko. Dear candidate, I have read your dissertation with great interest. You conducted a series of nice studies that also resulted in good quality publications. What struck me most was the extent and complexity of the SCALA project and its associated research. What made it even more complex was the interference from the COVID-19 pandemic during the implementation of your SCALA project. My first questions are about your findings on the motivational and organizational factors associated with healthcare providers' alcohol screening behavior. In chapter 5 of your thesis, you analyzed the motivational and organizational factors of the healthcare workers that were associated with performing the actual alcohol screening of their patients or clients. A remarkable finding was that the role security of the healthcare workers was associated with performing the alcohol screening, and then in particular, a higher role security was associated with a lower level of alcohol screening. What is your explanation for that rather counterintuitive result? Do you have an explanation?
Highly esteemed opponent, thank you for your compliments and question. Yes, I was thinking about that quite a lot because it is indeed counterintuitive. You would expect, high role security is associated with, more screening in practice. Few of the possible reasons for that are one, the average role security, so like the mean was already quite on the high end in comparison to other studies which have also studied it in Europe. It was I think a bit 5. So in that sense, just the increase in role security, any further additional increase in role security itself would not have anything to do with behaviors in practice. And then that might also be then related to the next one, which is kind of showing that in a way like the motivational part of how much do you feel like they should be working with drinkers, or that you are have the security in your role to working with drinkers. That's in a way less important and less relevant in terms of its impact on actual outcome of screening in the context of all of the other broader factors.
Yeah. Could it also be that it had to do with the validity of the measurement of role security?
Yes.
Because I saw that the instrument you use for that, it was self-developed and...
No, your role security was actually a measurement, like it was the SAPPQ. That's the short questionnaire on alcohol and attitudes. Yeah. So role security and therapeutic commitment were actually based on a scale that has been previously used many times, but it has been also criticized for. It might also be just the validity of the measurement. Okay, indeed.
Thank you.
Yeah.
Another interesting finding from the study was that leadership was positively associated with alcohol screening. What kind of activities or behaviors could a manager of a healthcare center do to increase the alcohol screening and advice in his center? Can you say something about how a manager could do that? What kind of behaviors would you expect from a manager?
So that there's different things any kind of central leadership or managers can do. Part of it is related to the it's very related to the practice of alcohol screening. For example, just allow this kind of regardless of there's any policies around it in surrounding environment, but just that on institutional level, he could make it organizational practice and also provide the providers with the materials. That was very important. I mean, you can tell them to do it, but if they don't have any brochures, leaflets, instructions how to do so, it will not happen. So that's one of the things that manager can do. And then I would say also just, role of the managers is also a bit broader, just on organizational level and what kind of organizational culture and practice they encourage, in a sense. Do they encourage innovations in their practice. So maybe some providers would bring that in by themselves. Or are they very by the book and nothing else can be done apart from what's in your job role? Yeah.
Thank you. Oh.
Sorry, Professor van
Thank
der
you.
Borne.
No, that is fine. And you have to go back to director.
Daša Kokole, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all all your time. 'Cause I'll go the extra mile.
Daša Kokole, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor de Vries is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor. Please all rise.
First, a question. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Daša Kokole, the degree of doctor and grant you all rights attached by custom and law. And as evidence of this, I now present you with a degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Dear Dr. Daša, it's the first time I now call you like that, Dr. Daša. Early in 2018, the Scala project started, and there were two excellent candidates and two places. One at Maastricht University and the other at ESADE in Barcelona, Spain. And the team decided that you would be the excellent candidate for the Barcelona position. So how to do this? As you were living in Maastricht, and the other candidate, Adriana Soloway, who defended last week, would also be working at her university. So we wrote an email to Sabine Bulic of the Capri Research Institute, and she organized that you became appointed as a researcher, as an external PhD candidate, and she did all the necessary paperwork. So officially you were appointed as ESADE, but working at Maastricht University. But the situation changed after 1 year, and then you were also appointed at Maastricht University because there was a just simpler solution. And actually, we already met before as I was involved in your master thesis, and the impression that I got then is still relevant. You are a very hard-working person and able to simplify complex matters into more simpler and consumable pieces of work. And this is what you very much needed in the Scala project, where your tasks were concerning work package 5, the process evaluation. And you already sent us an outline of your plans on April 26 in 2018. When I was looking back at the emails, I noticed, wow, that's kind of early. And I think this also illustrates very much the way you approach things. Very well prepared, clearly outlining what you wanted to do, but also open to suggestions from other people. And well, we've seen what the results are. You just defended successfully your thesis with 7 chapters, the 5 published papers, and you're involved in even more publications, as can be noted at the end of the thesis, where you list 16 publications, and I guess there are probably already more now. So this reveals another excellent quality of you. You are a team player, eager to listen and to contribute and to find compromises where needed. And I think that's therefore why people like you like to work with you very much. And I think this is also illustrated by the fact that after Scala, you became involved in the Alhambra project, and by the fact that you're now working for the WHO. So the Scala project actually now, by the second defense, now comes to also an official end. And I think all the work that has been done in the Scala project, and also the work of Adriana and Daša, could not have been possible by all the input of the 3 members, for which I would like to thank them, and in particular, of course, the mother and father of this project, Eva Lopez and Peter Anderson. Without their effort, this work wouldn't have been possible. But that does not mean that your input was not significant. No, on the contrary. You showed that your work has contributed quite a lot. And it was not an easy project, the Scala project, because there were many other tasks, which I already memorized, or referred to also last week. You had to combine it with the reporting, and you were really involved in so many different aspects of the teaching at our university. And of course, there was also COVID, it was already mentioned, that messed up the whole planning for the people in Mexico, Colombia, and Peru, but also for you and all other people, and of course, also for the mother and father of the project, even Peter. So very well done that you found ways to cope with this. You were in the middle of the discussions on how plans had to be altered, and we could still meet, of course, during the time, but now via Zoom. It was a challenging time, but I'm very glad that we could remain working and meeting online in a very good spirit, and this has always been the case. So, Dr. Daša, your Scala time has now ended, as I really liked working with you very much. You were always motivated, eager to continue to develop and realize your plans, open to changes of plans, but also motivated to defend your own. And when it was needed, you really defended them, and I think that's a good sign of a researcher. You have very good analytical and writing skills. You can be trusted when things have to be organized. And as said before, you're a very nice person to collaborate with. So you're now working for the WHO, which I think is an excellent job. But I also believe that an academic future focusing on processes such as implementation and process evaluation could also be very suitable. Well, you can never tell what the future will bring you and what you want for the future yourself. For now, I want to congratulate you with your achievement, and of course, I want to include your family and friends as well for this, for this achievement that you realized today. Well done, and I give the word to Lisbeth Merken.
Thank you.
Dear Daša, quickly after you started your PhD, you already blew me away. How you stood there full of confidence presenting your first Scala work to the whole Scala team when we met in Barcelona. As if this was daily business for you. I was very impressed how you handled those meetings, engaging professionally in such an early stage of your PhD. The Scala project seemed to fit you perfectly, and you quickly found your own way of working within a large team of researchers from Europe and Latin America. Teamed up with Peter and Eva, you also got many other great opportunities on the side of the Scala project, and you took them all with both hands. It must not have been easy, but you worked really hard to plan, organize, and combine it all, and this now is mirrored in your impressive list of other publications above the ones presented in your dissertation. I really admire your immense dedication even during the COVID pandemic. And then one would think, with so much on our plate, there would not be much time left for anything else. But nothing could be further from the truth. I think of outside lunch walks, backyard lunch walks, coffee walks, hikes, cycle tours, with or without colleagues. You are a very active lady, or should I say Mrs., as you are also married now with Andreas during your PhD. Dear Daša, after 5 years, my role as your supervisor now officially has ended. Thank you for taking up this big challenge together with us. I am proud that I could be part of your team, and although our roads will separate or are already maybe separated, you are always welcome back in the future. Congratulations with this great accomplishment and your new title. Furthermore, I would like to congratulate also Andreas, your parents and other family members, also on behalf of Hein and Eva, and we wish you all a beautiful day.
Thank you.
Dear Dr. Kokole, also on behalf of Maastricht University, I congratulate you with the degree you have acquired. I can tell you that when we discussed the quality of your defense, I heard a lot of compliments about your thesis, about the way you defended it, and especially also about your hard work, and that has been mentioned just now. Of course, I'd also like to congratulate your family, friends, and colleagues, the people you worked with, because I know that writing a thesis is not the work of one person, but you've undoubtedly worked with a lot of people. So thank them as well, and congratulate them as well. I'd like to congratulate your supervising team, present here, and Dr. Eva Jane Lopez, who's not here, unfortunately, but maybe she will watch later on online and see how you really did very well. I'd like to thank the members of the promotion committee for being here, for spending their time in preparing and asking their questions. And with that, we come to an end of this session. I wish you a lot of success with your future career, and I close this academic session.